A very good morning to one and all. Thank you, Dr. Bala sir, for giving me this wonderful opportunity. I'll be talking about navigating the pitfalls while treating a uveitis case. So, after we successfully diagnose a case of uveitis, we still face a lot of challenges during the course of treatment. So, like if there is incomplete history from the patient, which was missed in the earlier stages, or if the clinical picture completely changes while treating the case of uveitis, or there might be even side effects of the medications which we are giving while treating the uveitis, or in spite of maximum treatment, the patient may end up with vision threatening complications like inflammatory CNVM involving the macula, and we are ending up losing vision of the patient. So it is always better to choose a therapeutic agent and make sure we balance their ability to cause disease remission against their potential side effects and toxicities. So our first case here is a 10-year-old male who came to us with sudden defective vision in both eyes associated with redness and pain. His vision in the right eye was 636 and left eye was counting fingers close to face. So this was the clinical picture showing disc edema, multiple serous detachments, which is very typical of Vogt-Koyanagi-Harada disease. The child was allergic to fluorescent dye, so we could not do an FFA. But this is the OCT showing large serous detachment. So after the routine blood investigations, we started the child on first IV steroids, followed by high-dose oral steroids. Then we later on added methotrexate. But in spite of adding one immunosuppressant, the inflammation was not coming under control. So we had to go ahead and add a second drug, which is mycophenolate mofetil, 250 milligram BD. So with this, the child was under remission. He went on to develop steroid-induced glaucoma though, but inflammation was under control. But 8 months later, there was persistent inflammation. Again, there was another bout of inflammation. Hence, we had to step up the immunosuppression, and we added a newer biological agent, TNF-alpha inhibitor, adalimumab, along with methotrexate, and we stopped MMF. So the dosage was 20 milligram once in every 2 weeks as injection for the first 10 months, and then once in 3 weeks, and then followed by once in 2 months. So we had to give this injection for a long period of time because at any point we were not able to taper down the oral steroids to less than 10 milligram. So which means the child needed this amount of immunosuppression. So ultimately, the child was under control. We were happy. The patient was happy. He was having 6/6 vision. But 3 years later, he gave us a surprise. There were small white granulomas in the AC. Now, these granulomas are not characteristic of VKH, so which means we are missing out on something now. And in the fundus also, there was a small granuloma superior to the disc. So adalimumab, though it is a TNF-alpha inhibitor, which is used in the treatment of treating non-infectious uveitis like sarcoid, BKH, sympathetic ophthalmia, paradoxically, this TNF-alpha inhibitor, while inhibiting, it can release a lot of complement factors, and it can release a lot of cytokines, which can paradoxically cause sarcoidosis. So the drug which we have introduced to reduce immunosuppression has actually built up a new disease called sarcoidosis. Literature has a lot of cases reported with adalimumab causing sarcoidosis. So we thought maybe this child is developing sarcoidosis following adalimumab. This is the OCT showing subretinal granuloma. We anyway went on to do a repeat CT test just to rule out tuberculosis or to look out for any hilar lymphadenopathy because of sarcoidosis. And ultimately, we stopped adalimumab and we hiked up the oral steroids along with methotrexate. Inflammation was under control, and we thought we achieved the diagnosis. But 8 months later, there was another recurrent inflammation. So now this time we stopped. We gave a pause. We did all the blood investigations again. Now we had a surprise. The MAN2 test, which was initially negative at the starting of the case, was now positive to be 17 millimeter. And the clinical picture now showed multiple small granulomas in the eye, in both eyes, in fact, with some kind of pigmentation scars. So this is usually seen in case of tuberculosis. So without any further delay, we ultimately started ATT. So the child has, uh, because of the immunosuppression, the child has developed an infection, which is tuberculosis, and we had to treat the child with ATT. After 6 months of ATT, without any further delay, we immediately switched him back to azathioprine, which is a milder immunosuppressant, just to make sure that the old VKH disease doesn't come back. So his final visual acuity is 6/6 in both eyes, and there's no active inflammation at present. So this case, uh, it warns us that we have to be more vigilant during treating uveitis. We'll have to be more vigilant. We'll have to pick up even small signs of infections, whether it is the blood count or any changing clinical picture. We'll have to be more careful. In the one of the largest studies, that is Visual 3 study, which was done on non-infectious uveitis patients with the anti-TNF alpha therapy, it showed that 65% of patients developed infections during the study because of the newer biological agents, and 5% of them, that is 20 patients, developed TB, one active TB and 19 latent TB cases. And the average duration from the start of anti-TNF alpha inhibitor to the development of TB was found to be 18 months. So moving on to the second case, we have a 45-year-old female, no known comorbidities, presented with redness, photophobia, and defective vision in both eyes. Her BCVA was 6/9 in right eye, 6/6 in left eye. And she gave us a very vague history of traumatic insect bite, wasp bite on the right side of the face. So our diagnosis was bilateral anterior and intermediate uveitis, and with the DD of query leptospirosis, bar traumatic endophthalmitis because of the insect bite. So we treated her with a course of doxy and oral steroids. Then 3 months later, there was another severe bout of inflammation. So this time we hiked up the oral steroids, and immediately the next month, her vision in the right eye dropped to 3/60. So, and the media was completely hazy. So we had no other option but to go for a vitreous biopsy. Media clearing vitrectomy and intravitreal antibiotics were given, but the culture was negative for bacteria, fungus, or TB. After clearing the vitreous, when the view was better, we found that there were multiple small white subretinal infiltrates in the right eye. And even in the left eye, there were very few infiltrates seen. So now our suspicion was more in favor of a masquerade, whether we were missing out something systemically. So we went on to evaluate systemically, CT chest, ultrasound abdomen normal, MRI brain normal, neurology opinion was sought, VEP normal, CSF analysis normal. We just picked up a small multinodular goiter while doing a CT. So, but ultimately the endocrinologist also gave a normal report. So we went on with oral steroid treatment. Her lesions in the right eye was resolving with some amount of scarring, but the left eye kept worsening now. So because of this, we again did a biopsy of the left eye, and we could not find any malignant cells. And now we had no other option but to go for a PET CT, whole body PET CT, which again turned out to be normal, other than some increased metabolism in the thyroid gland. So the patient went on with steroids. Her vision was slightly improving now with steroids. So patient was also happy, and we were also happy because the lesions were slowly starting to resolve now. But the OCT was not very convincing. We had these hyperreflective outer layers. So, suspicion of RP epithelitis was made. But then again, we went on to continue with the oral steroids since there was no drop in the vision. 5 months later, this was the clinical picture. Right eye had some new lesions with some old scarred lesions, and the left eye had diffuse pigmented chorioretinal scars, healed scars. So this picture again, usually pigmented scars are seen in TB. So we thought, why not give a trial of ATT just to see how the reaction is. But within 1 month of starting ATT, the inflammation was again worsening. And this time, the patient who usually walks to our department came in a wheelchair with slurring of speech, generalized weakness of the body. Her BP was dropping. Now, this time, we again had to refer her to a neurologist. Repeat neuroimaging was done. Now, the MRI brain showed multiple hypointense enhancing mass in the splenium of corpus callosum, left thalamus, right cerebral hemisphere with extensive surrounding edema, suggestive of CNS lymphoma. They again went on to do a histopathology from biopsy, and it was positive for BCL2 and CD20, which is again suggestive of diffuse large B cell lymphoma. So the patient had to undergo chemotherapy with methotrexate. To us, after a point of time, she lost to follow-up. She underwent right eye cataract surgery. Her vision in the right eye is 6/6. Left eye is still to be operated. And as of now, she has completed 13 cycles of IV methotrexate. So this case is actually a case of primary vitreoretinal lymphoma. It is a subset of primary CNS lymphoma. And how come we did not get the CNS involvement in the beginning? Because only 16 to 34% of patients with PVRL have CNS involvement at presentation. And a mean interval of 8 to 29 months later, and almost 92% of PVRL cases presented with intracranial lymphoma. And 15 to 25 of patients with the primary CNS lymphoma ultimately develop an ocular manifestation of their lymphoma. So it's vice versa. And cytopathology remains the gold standard diagnostic method. And a recent update is that if suppose the pathologists miss the malignant cells from the vitreous biopsy, because the malignant cells in the vitreous are very fragile. After taking a biopsy, if they don't immediately put it on the smear and read the cells can lyse immediately. So they might miss on the diagnosis. So in that case, we can go ahead with genotype analysis, where we can find MYD88 mutation. And even if the cells are in the aqueous, if there is anterior uveitis, we can take an AC tap also and find out this genotype analysis. And the 5-year survival rate of B-cell lymphoma is 30%. Third case is a straightforward case, 36-year-old female presented with defective vision in both eyes. Again, it was a case of VKH with multiple large serous detachment and OCT showing subretinal fluid with large detachments. And this is an FFA, very typical of VKH, showing multiple pinpoint leaks, disc leaks, and pooling of dye at the areas of detachment. So she was treated with IVMP, 500 milligram 3 days, followed by a high dose of oral steroids. But as we were tapering down, after she reached 20 milligram, we went on to taper it very slowly, monthly tapering. 4 months later, she had complaints of hip joint pain. So any middle-aged lady on steroids, if they have complaints of hip joint pain, we have to suspect avascular necrosis of the head of femur. We went on to do an MRI. She had stage 3B or 4 avascular necrosis on the right side and stage 2 necrosis on the left side. So ultimately, she had to undergo a total hip arthroplasty for the right side. After arthroplasty, the patient is doing well. And for the ocular part, we had to immediately stop oral steroids and put her on immunosuppressant methotrexate 20 milligram. Now she's doing well with a vision of 6/6 in both eyes. So steroid-induced avascular necrosis is the most common non-traumatic cause of AVN. Incidence is about 3 to 40%. Why femoral head and not any other joint? Because the femoral head has these tiny end arteries which are very small in size and they are prone for occlusion, leading to ischemia, even with trivial disturbance in the local circulatory system. So Liu et al. Reported that a daily dose of 40 milligram steroids increases the risk for AVN, and above this level, every 10 milligram of oral steroid increases this risk of AVN by 3.6%. So the steroids, ultimately, they increase the intraosseous pressure, constrict the blood vessels, thus cutting the blood supply, and ultimately the oxygen-starved tissue dies off and weakens the bone. These are some of the other pathogenesis which have been reported, like altered lipid metabolism, like patients with hypertriglyceridemia, they are more prone for developing avascular necrosis, decreased osteogenesis, intramedullary fatty infiltration, inhibition of angiogenesis, endothelial cell injury, and intramedullary hemorrhage. So my take-home message would be the reverse of the wise monkeys of Gandhi ji: see, hear, and speak. Be vigilant, Look out for signs of infection or any other change in clinical picture while you're treating a case of uveitis. Listen to the complaints of the patient. We should not neglect even a small complaint of pain. Like patients on methotrexate or steroids often come with pain, complaints of generalized body pain or fatigue. So without neglecting these small complaints, we should evaluate and look out for signs of any infection or avascular necrosis. Intervene at the earliest. Do not hesitate to do repeat blood investigations or any other investigations which was normal before, because the picture might change at any point of time. And proper counseling of the patient should also be done, because so that they come to us in spite of worsening of inflammation, they come to us properly so that we can follow up on the diagnosis and treatment. Thank you.